Welcome back, everyone, to Diversion Insights. My guests today are Tyler Cramer. He's an inpatient clinical pharmacist at Boone Health in Missouri, and Kayla Sewell, a PGY2 Pharmacy Informatics Resident at Lifepoint. Both of these pharmacists have done some research on optimizing waste. Tyler has published in AJHP, and his title is Maximizing Opioid Stewardship through Fentanyl Vial Size Optimization in an Independent Hospital. Kayla recently did a poster presentation at IHFDA titled Analysis of the Financial and Workforce Impact of Controlled Substance Drug Waste in a Community Hospital. For those of you that were at IHFDA, and we did the panel with John Hertig and Chris, and we discovered that titles for pharmacy research papers are quite long. We have to come up with some clever titles, but it's very descriptive of what you did, right? So we're going to talk about that. And let's first start by getting to know our guests a little bit. And Tyler, tell us about your history with your career and where you are now. And then what prompted you to do the research? Were you told to do it? Is it a passion of yours? Did something precipitate the idea for the research? So let's start there.
Yeah, thanks, Terri, for having me on here. Listen to a couple of your podcasts, and I think they're great addressing, the entire story of what's going on with the diversion and opioid crisis here in America. And a little bit of background about myself is I graduated from University of Missouri, Kansas City School of Pharmacy. I went to the Columbia campus. So for those of you unfamiliar with UMKC, they do have satellite campuses. Main campus is in Kansas City. There's a satellite in Columbia, and there's a satellite in Springfield. So I went to the Columbia site. It was a little bit more, I have a rural background myself, so it felt a little bit more like home. It was closer to home, and I liked kind of the smaller class sizes that were there. So starting out, I was an intern at Boone Health as a pharmacy intern and served there for 4 years. And after I graduated, I just jumped right on board as an inpatient pharmacist, and haven't looked back since. So then instead of doing a residency, I'm kind of learning as I go and picking up a lot of things. I do volunteer on ASHP's, one of their section advisory groups. It's the Small and Rural Hospital section advisory group. So every year we publish resources and put things out there for the small and rural community. As far as the opioid stewardship and the study that I've done is Boone Health used to be an umbrella under Barnes-Jewish, which is out of St. Louis. They're kind of a very large health organization, and now they're partnered with St. Luke's as well out of Kansas City. But around 2020, we separated from that umbrella and we became an independent hospital. And during that transition, we realized, hey, Barnes-Jewish, since they were our parent, basically company, they were doing a lot of the things that we should have been doing for us. And one of those was they had their own opioid stewardship company, our opioid stewardship committee, and they set out guidelines for our hospital. When we went independent, we no longer had that. And our pharmacy director was like, hey, does somebody want to try to tackle this? I wanted to get more leadership experience. So I took the ASHP opioid stewardship certificate training course that gave me a little bit of experience on what opioid stewardship means. What kind of metrics we need to look for and how to implement that into a health system. So then we put together over the course of a year our opioid stewardship committee. We looked at what kind of metrics we could start measuring, which ones basically were going to be the low-hanging fruit, which ones we could tackle easily. One of our Fresenius Kabi drug reps, he was actually coming around and talking about their new Simplest syringes and the studies they had out. Showing, reduced waste, reduced wasting events. And so that kind of really inspired it. And I was like, hey, I think we can implement that here to our hospital size, because the hospital they looked at in their study was about a 300-bed hospital. And that's what we are here at Boone. So that's kind of what prompted me to pursue my study and also a little bit of background.
Great. Perfect. Okay. Kayla, how about you?
All right. Well, wanted to thank you as well for having me today. Really excited to be here. My pharmacy journey started out long time ago. Back in 2012, I was a technician. So from 2012 up until the time I went to pharmacy school, I started in 2019. I was a pharmacy tech, and then when I started in school, I transitioned to a pharmacy intern. So I had a lot of experience operationally wise from both community pharmacy in the outpatient world and then also in the inpatient world, especially compounding a lot as well at a very, very large 1,000-bed hospital here in Nashville, Tennessee. So I had the opportunity for that insight. That brought me to pharmacy school. I graduated in 2023 from Lipscomb University here in Nashville, Tennessee. Also was really attracted to it because it is smaller. We do have University of Tennessee here in Nashville too, much larger. But I did find that I wanted to stay in Nashville for the great opportunities in healthcare and just experiences and relationships that the university was able to offer to me as a student. I also did go on to complete a dual degree there. While I was there for my PharmD, I did a master's in informatics. My interest in informatics grew kind of into my P1 year there, and so I decided to pursue that degree. And then afterwards, I went on and got accepted into or matched into a residency through Lifepoint Health. It is a combined PGY1 and PGY2 residency program. So I did start in 2023, right after I graduated. I did complete my first year residency with it was at a very small rural community hospital there, kind of the flagship hospital for them. But Lifepoint Health as a whole, it is kind of a family of hospitals. Lifepoint, they do own lots of smaller community hospitals, more so out in the rural areas in the country as well. About 63, 64 acute hospitals, and they do own a lot more behavioral health and inpatient rehabilitation centers as well. So really great experience so far. I have been able to see a lot of different flavors of multiple EHRs, different technology, a lot of just different practices as well. So it's been great this far. But part of kind of why I was interested in my research was that it was my PGY1 research project. And so my very beginning of last year, my residency, had a lot of options presented to me. So normally your program will kind of have all these lists of ideas of things that they kind of want to see, they want to kind of study, and they'll kind of present you with a lot of different options. And so my program was fun. They presented it to me in a Shark Tank fashion. And so they had all of the kind of project mentors there and kind of presented the project to me. And so I actually ended up picking the one I did just because I felt like it would make a lot of like meaningful impact for the particular hospital itself and just the ways that it can be incorporated like over the entire Lifepoint family of hospitals as well, kind of standardizing that and bringing that. Any of those results come up, we can, we can actually plan to incorporate those into our hospitals as well. But again, drug diversion, it was one of my interests from the get-go, so I was kind of naturally drawn to that. So yeah.
Great. Well, and I love to see technicians that go on to become pharmacists because you start at the beginning and you really have that full understanding of what that all involves. And I think it also helps when you get on the management side too, because you've been there, and so I think that's great. So good. Okay. So interesting history for both of you. Let's talk about the studies then. So we'll start with Tyler. Tell us about your study. What was your inclusion criteria? What was it based around?
Yeah, so like I said, a big part of our study was first identifying that we didn't have an opioid stewardship committee, and we kind of needed leadership in order to start to implement all these practices that we've been implementing over the past 4 years. So we first started out by putting together a multidisciplinary team that could make these decisions and make these changes throughout the hospital. And so, like I mentioned, Fresenius Kabi, I think one of the studies that they presented was the implementation of simplest fentanyl citrate injection, the 50 mics per 1 mil.
So fentanyl, implementing the simplest.
Yeah, so that study was kind of, like I said, presented to us from the Fresenius Kabi drug reps that we had here at Boone Health. And they kind of basically were trying to show us these new syringes that we could use. So we started out, we looked at all of our Pyxis data, what our waste data was, we originally had the 100 mic per 2 mil syringes out, and we're like, hey, all of our pain doses are 25 to 50 mics, kind of on the bigger end, and sometimes we're using 12.5 mics. So it doesn't make sense to have 100 mics of fentanyl out there whenever we're wasting half the dose every time. So that was the starting point. Is we saw that the inpatient side, or the inpatient units, those are going to be the easiest ones to change, because a lot of them don't have a lot of pushback. It's nurse driven. So we had a lot of nurse buy-in, and they were comfortable with making that change. And then also the ER, we identified, they were wasting quite a bit almost every time they were using fentanyl. So it was going to be a big workflow change for them, and it was going to save them a lot of nursing time. So they were also pretty adamant about making that change as well. The other units, like OR, anesthesia, cath lab, those people are a little bit more set in their ways. And it's usually providers, CRNAs, people who may or may not have a little bit more pushback, and that's kind of how they practice. So we didn't want to address them at first. We wanted to get a lot of the data from the nursing side and the nursing units. That way we could present that to them and say, hey, look, this is what we're doing throughout the entire rest of the hospital. And this is, we're changing 60 to 70% of our wasting metrics. And when we had those data points, that really opened the eyes of all the other parts of the hospital. And they're like, oh, wow, yeah, we are wasting a lot. This can really help, our nursing labor, our CRNA laborers in the OR. We're not having to grab a second clinician and say, hey, I need to waste this, because our hospital policy, and probably most hospital policies, are utilizing 2 individuals to witness waste. That way there's a lower chance for diversion. So that takes a lot of labor. It takes a lot of time. I know, looking at a bunch of other studies that I had cited in mind, that those workflow or time to waste studies, basically, it's like $2.40 is the average waste every time we have to perform a waste. And fentanyl was our biggest contributor to that. So that's kind of what we looked at and what we zoned in on.
Okay. So fentanyl was the only drug that you picked, right?
Kind of. For the study, yes, fentanyl. Hydromorphone was a lot easier. We used that basically for our post-op ortho patients, and a couple times we'd use it in the ER, but we didn't use it nearly as much as we used fentanyl. And with the hydromorphone, we already had because of back orders and supply chain issues, I think in 2019, we had the 2 milligram per mil basically in all the cabinets. Then those went on back order. So we ended up getting the 1 milligram syringes, and then we got the 0.5 milligram syringes. So those just occurred because of supply chain issues, and we had already implemented that. The fentanyl was the headache one, because they use it a lot in the PACU setting. They use it for sedation. Right. They use it for all kinds of other procedures. And so changing all of our order sets, changing our procedure habits, changing what we're pulling, that took a lot more education. So the fentanyl was the one we included in the study because it was a lot more work. It was bigger numbers that we were changing. Hydromorphone and also morphine, those we all changed as well.
Right. Yeah. Okay. That makes sense. And it's very different on a nursing unit versus a procedural, right? Because nursing unit, they're only supposed to use the 1 dose and then throw the rest away. Procedural area, they can do that incremental dosing, and then they're like, oh, we don't want to go to the machine again. So you kind of got to, look at that whole thing, right? It's like, well, we like it when we have leftover, because then we don't have to go back. Yeah, exactly. Okay, Kayla, tell us about yours. What did you include in your study?
Yeah, so for my study, I actually included 3 different units in our hospital, and I purposely excluded the operative areas. The reason being so was because in the small hospital that I did the research in is in our normal inpatient units that I did, the ED, I did a, let's see here, it was the ED, the CCU, the critical care unit, and then kind of like a cardio floor as well. The reason I did that was because we have very standardized practices, and the practice of nursing and also pulling from our ADC cabinets is very standardized, and the way we waste our processes are very standardized too. So we do have a drug diversion prevention surveillance system that we use that also helps monitor that. But in our OR and perioperative areas, they don't have a very standardized process for, they have a different type of program or technology they use to document their administrations. And so it wasn't very easily done in that sense. And they have their own culture and different staff in there. So I really wanted to focus in on the areas that I knew that we had the most wastage from, and those were our inpatient units. But what I had done is I wanted to pull reports based on our wastage, and I did that by looking at our ADC reporting. So I went through and found the top 3 drugs that we did the most waste on, and that was fentanyl. That was the fentanyl 100 per 2 ml, and then the hydromorphone 1 per ml, and then the lorazepam 2 per ml. And so those are the 3 medications, the IV push, that we had the greatest amount of waste in. And also the areas that I picked in was also the areas that had the most waste in, but also because they were the most interesting, because they have similar standard of practice, but the ED is the Wild Wild West, we all know that. And then the CCU is a little bit more controlled, but we still have a lot of critical care and emergency situations there. And then the other unit, that's just your typical internal medicine, cardio unit that you would have. So you kind of see a little bit of everything in there, and as far as the usage is wise as well. But kind of the reason prompted this, again, John Turkick's study was a great model for that. I did try to model this very similarly. So I did do a lot of observing to these units, and it was great because I got to see a lot of just between the variation of layouts in the hospital where our ADC cabinets were located, the availability of staff to witness, and then also the proximity of the cabinet to patient care areas, and then also the proximity of where we actually are wasting them. So our little wasting bins that we had as well. So all these factors played into a huge part in that. And I did find that obviously in the ED, we had a lot more fentanyl wastage, whereas in some of our other units, we had more hydromorphone wastage as well. But really from the study, looking at how I could try to decrease that in any way. And I immediately found some areas to improve upon, and those kind of came up to be, what are we using? What package size? What strength are we using in these areas? And I immediately identified trends in what was the most common dosage that was being used in these areas and the most common wasted. And so I immediately identified that and found all these opportunities. So again, with nursing dollars, and then also with the amount of money spent on these medications and the amount that's wasted by that, think about how financially that could save a lot for the hospital, but also for the entire corporation. But lastly, not just that, the actual amount of physical drug that we're wasting every day, every hour, every week, every month. We do have all of our ADCs located in a very secure area, but the way that we do I guess you would say, waste them, we also have those little waste containers next to. We also have cameras as well. So we're, utilizing a lot of those wasting containers, the more medications we have from a drug diversion standpoint. And so just trying to find ways to decrease that overall. So.
Right. Yeah. Well, and then the nursing satisfaction too, right? Years ago when I was at an independent hospital, and finally hydromorphone 0.5 milligrams came out, and we put them in the ED, and they had to get used to the whole new syringes, but to them it was worth it. And all of a sudden I was their best friend. Right before that, I was just kind of an annoyance. It's like, we're going to go profile, we're going to do that. And they're like, but when the 0.5s came out, it was like, I went and manufactured it myself. I mean, all of a sudden they loved me, because it is so much work for them to, and they're going to waste it every single time there's going to be waste, or you hope there is anyway, because you don't want to go in 1 milligram necessarily. Right. Okay. So you did more drugs, but same principle. So tell us, Tyler, what were your findings in general? Did you, because there's the cost. You tell us this, is the fentanyl 50 more expensive than the 100 microgram? There's the other costs involved, but sometimes that's why pharmacies are not willing to purchase the smaller one, right? Because it's more expensive and they don't want it to go onto their budget, understandably so, but that's what you find. So what did you see in terms of cost of the drug versus waste and all of those costs?
So I think what I had heard was you were mentioning the cost associated with the findings and what the numbers look like.
Yeah.
from our study. Is that correct?
Yep. Mm-hmm.
Okay.
Yeah. What you find?
So,
yeah.
Yeah, so from the study, like we were mentioning, the ER had the biggest impact. And like you said, when we demonstrated this with those 50 mic fentanyl syringes, yeah, we suddenly became their best friend because they went from, rough numbers, not what was quoted in the study, but we're doing like 300 waste events in the ER just for fentanyl alone. And when we switched these, all of a sudden we dropped down to 15. So we had we've maintained that number. Usually, if I have more than 20 waste events in a month that I'm observing, then something's probably wrong, or somebody needs training, or we've had a busy ER month.
Okay. So that was a big decrease in the number of waste that you did. Okay, so you went down to much less waste. That was a huge difference. What you find from a cost perspective? Obviously, you were saving money there.
Yeah, so from a cost perspective, so this was kind of this was harder to pitch to like C-suite is, technically the 1 mil vials and 1 mil syringes, they cost more than the 2 mil vials that were available. So from a drug cost standpoint, these are more expensive. So then, using the studies that have come out, like from John Hertag and the cited in my study about how much time it takes to waste, the supplies that are going into it, like the syringes, the needles, all that kind of stuff. It's $2.40 was the rough number that came out of that study. So like looking into that, I think it's $1 difference from our AWP cost between syringe and vial, going from the 100s to the 50s. So then using that arbitrary labor amount, then we're netting, $1.40 per waste event. So since those are, fake numbers, we're saving money. It's not actual spend money or drug spend money. That's always hard to pitch to C-suite because they actually want hard numbers like, hey, this is really what this is costing us. But the bigger thing was showing them the micrograms of fentanyl that we went from is since the study, rough numbers going from like September 2021, we were wasting like almost 80,000 micrograms of fentanyl a month, which was an enormous amount. And during COVID, we were using a lot more fentanyl, definitely for like sedation purposes and pain purposes. But since then, we've used less. So that kind of helped influence that number to come down. But now, like even through the whole health system, that 80,000, now we have roughly 15 to 20,000 mics is our normal monthly waste. So showing the C-suite that number, they're like, oh, wow. So there's a lot more fentanyl that's not going out. It's possibly being pocketed, not accusing anybody of diversion. But if we're eliminating the fact that they have to waste it, then most likely we're eliminating those diversion opportunities. Right. So that's really, those numbers help drive it. And like you had mentioned at the beginning, we have continued to implement this study into more areas, and that's how we keep driving our numbers down from the numbers that I'd actually published.
Okay. All right. Wow. That's a big difference. Kayla, what'd you find?
All right. So from our 3 units that I did look in the study in our hospital, we actually, my first impression was that there's going to be a lot of fentanyl wastage. We utilized the 100 micrograms per 2 ml. And at first, that's exactly what it looked like. But once I started digging deeper, I realized that our hydromorphone was way larger in terms of waste, and not just the actual amount of wasted product of milligrams of the drug being wasted, but also in just the cost. So at that time, fentanyl was very, very cheap to us from our wholesale distributor. And hydromorphone was the most expensive. It was more expensive than diazepam as well. And so it really started to hone in on that one, just because it was the big one. So in our ED, we found that because we have that 1 milligram per ml, and again, the most average dose is going to be that 0.5 milligram. And so just looking at that, I did find that because of that extra about half amount of our hydromorphone was being wasted, it has the highest cost of pharmaceutical waste in like terms of money per se. And so looking at that, it takes the longest to waste as well, because I did find in just across different units. Some will hold on to it, some will go administer it and hold on to it, come back, and they may get distracted in the patient's room or distracted along the way. And then it was a lot easier for, say, other units when you had a buddy that was sitting there right next to you and you could immediately waste it upon, dispensing it from the cabinet. So it was much easier. But in different places, it was hard to find witnesses. So I found that because of that variation in our units and our patient care areas, that one did take the longest, which cost more kind of in the financial standpoint of nursing dollars to waste, so the longest time to waste there. So, but that being said, lorazepam was also another major player with that. As we all know, lorazepam doesn't come in a lot of options there for our sizing and standardization of dosing. So we did have the 2 milligram vial with that. And at the time that this was happening, that was when we did have a lorazepam shortage as well. So it was kind of hard to get in lorazepam itself. But again, that one, it comes in a vial, whereas our hydromorphone and our fentanyl came in syringes at the time. So that did pose a little bit higher time to waste or workforce time waste as well, because you're taking an extra step of drawing up that waste in another syringe and then also wasting that as well. So with that, I found that also to be the kind of highest in the time it takes for workforce time waste as well. So with this project, honestly, fentanyl kind of was on the lower end, and I mainly focused on on our hydromorphone and lorazepam and what we could do to kind of mostly optimize what we're ordering, where we're storing it, that type of thing, so we can decrease all of this waste we're seeing. And so basically what I had kind of found is that we had about close to $2,000 in savings if we were to switch the hydromorphone over to our 0.5 milligrams.
$2,000 per month?
Yes.
Okay.
So,
Okay.
And so that was just from my study. That was extrapolated from my study data points as well, and the time it took for that as well. And then also for the lorazepam, again, that being also taking longer to waste as well. That was around, if we were to change that from a vial, our wholesaler did offer a syringe version of lorazepam at the time, which in theory would make it a lot shorter for the nurse to waste per se. And so instead of drawing up another getting the syringe out, extra steps, you're eliminating extra supplies, you're eliminating extra time it takes as well. So just kind of eliminating, based on, again, price of supplies and then the time it actually takes to do that. That was roughly around $3,000 in savings for that, just for the workforce time aspect of that. Not just, again, the time it takes to waste that medication there. So
Wow.
Really honing in on that. But the biggest thing I did is I really wanted to see kind of extrapolate this across a year. So that's what I kind of did with my results, is I extrapolated my one study from my small hospital, extrapolated across the year, and basically found that those savings, if you extrapolate those to our 63, 64, 65 acute hospitals there, you could have a really great impact on savings there. And so if I extrapolated that and changing just those two things there from the lorazepam and the hydromorphone, there was approximately $120,000 saved in just switching over to that hydromorphone, about 0.5 milligrams, and then $273,000 from switching over to lorazepam. And so that's huge savings. And for us, the amount to switch from those packages into those different dosage forms, we found that it was very little and very minute. So it was cents to dollars more. And because these are high utilization products, it would result in much more greater savings in other areas, such as, our waste bins we're putting the products in, the time it's taking the nurses, better nurse practices as well, higher satisfaction for the nurses as well, and then also just removing that drug from being out there. And so, and just from my experience of, actually looking at and, reading about different drug diversion, stories that come up in the news and things, decreasing and just eliminating that amount that can be found is huge. And in this case, not only are we reducing that amount from switching products, but we're decreasing the amount of money spent on that waste and the product itself over time. So it was a really great finding.
Yeah. Wouldn't it be nice if you could get a percentage of your savings, your research savings in your salary? Bonus, PGY2 bonus. Wow, yeah, that's big numbers, and especially when you have many facilities that you can roll that out to.
Yeah.
Let me clarify on the Ativan, the lorazepam, because I was like, ooh, is there a smaller one available? So there's not a 1 milligram available, but there is a syringe available now?
Yeah, at the time when I did my findings on this, our wholesaler had the option to purchase a syringe form of 2 milligram. So, and this was so during a time that I collected this data, there was a shortage, so we were unable to get a syringe in that. Okay. But when I went back and I looked at what was available at the time, this was a month or two later. This was after the shortage they had, it was on back order. They actually had a syringe to be able to purchase. So yeah, okay. And I mean that's a win either way. You're leaving a little extra time out to waste. Extra supplies and so forth. So I thought
and then it's just it's cleaner that. Yeah.
If you're referring to, I was going to say if you're referring to maybe the ones that we could purchase as well. Correct me if I'm wrong, but is it just the Carpuject like syringes that are available? I think that's all we can purchase is the Carpuject and then the vial. That's why we've had the reservations against the syringes, because the nurses always lose that device and then they're getting a syringe and drawing from the top of the Carpuject. And we were looking to implement that here and we're like, oh yeah, we can do that. And then we saw what it was. We're like, oh, we don't want that. We tried.
You're right.
Not speaking brains or anything, but it's another diversion risk that we kind of looked into. And unfortunately, morphine comes like that a lot. It's always in like Carpuject that we receive.
Yeah, no, yeah. I remember those struggles too, going back and forth. And I remember when I first found out that they didn't use them, I'm like, well, how do you get the med out? And exactly. Then I'm like, well, what?
Yeah, they're like, watch this.
Yeah, exactly. But if they do it right, then you've also eliminated potential infection control, right?
Yeah.
Because they're not drawing out of the vial. So so that's another reason if you can get them to use the Carpujects like they're supposed to. Yeah. Okay. Well, that's great. And I think intuitively we know these things, when I'm performing deep dive audits. That's one of the things I look at, especially in a procedural area, but really everywhere. It's like, there's a pattern here, diversion or not diversion, it doesn't matter. But as I start to see the waste amounts, that's often feedback that I'll give to the director of pharmacy. It's like, look this is how much less would have been wasted had you had fentanyl 50 microgram vials instead of 100s, and help them see that. And sometimes what I find, it's a matter of there was a shortage, so they switched it out and they never went back. Or, oh yeah, we have those in other areas, but we don't have them in here. I'll look at that. And so it's just kind of that team effort that somebody else is looking at it, the big picture. And it's like, oh, here's a change you could make. And, you're going to save something. So yeah. And you've addressed the diversion, right? How to tie it back to, okay, we can save some money. We can make people happier from a workflow perspective, but then there's the diversion piece, because oftentimes that's where it starts with the waste, because it's easy to think that, well, it's just going to be thrown out anyway. So I'm not really doing anything that wrong, they can justify. So eliminating that piece then is good.
Yeah. And I think because there's so many different ways to waste something, and I say that because I observe many different, unique behaviors and things that happen, and it's just interesting. The human aspect plays a big part in that as well. And, even if you have cameras set up, you have everything in the world set up to kind of prevent, people from even thinking of doing that. It still happens. It happens, and people think of new ways all the time. And just having the ways, prompts them to think of new ways, because they're like, hey, I have half of this left. What am I going to do with this? I'm wasting this all the time. No one's going to care. It's a little bit of this waste that's already supposed to be wasted is going to go away. So I think that's a really key piece of trying to eliminate that as much as possible. So.
Absolutely. So is it safe to assume then that based on the research, the facilities have implemented the change? You have brought in new products that are smaller strengths and implemented it?
At the hospital, I did this study at the research, and they have actually incorporated the smaller versions of the hydromorphone till this day. They are looking at the the fentanyl option, but right now are keeping the diazepam option. That's just due to where they're stocking it elsewhere in the hospital as well. They do have another unit where they do see a lot of hospice patients who do come through, and diazepam is unfortunately one of their more common comfort meds, where they do use a little bit larger doses in there. So it would make more sense to stock that larger 2 milligram there. So yeah. And that's just from a practice standpoint. What is your patient population look in your hospital? And again, that was a unit I didn't include, and so I found that out after the fact. And so it's perfectly reasonable to make those decisions based on your patient population and kind of what you see as it comes to your hospital as well. But the other two, again, hydromorphone is in play. Fentanyl is coming up next, and hopefully looking into see kind of what that input actually looks like. After a little while, it was very recent, in the past couple months they have done this, so hopefully it will produce some really great savings and reduce some waste, and we can use that as a model hospital and kind of go from there and kind of incorporate across everywhere else. So yeah.
For sure. Yeah. And Tyler, I believe you said that the fentanyl and then the hydromorphone kind of happened naturally after stock came back.
Yeah, with the supply chain issues, once they saw the hydromorphone sizes that we had to offer, they're like, oh yeah, we're not going back to this because of wasting. And you and Kayla were saying it's very interesting that during COVID we had my wife's a nurse, so I get to hear all this stuff firsthand. And but we had a big nursing shortage. Everybody was moving hospitals. So then we have nursing ratios on some inpatient units that are 5 to 6 patients to a nurse. So eliminating the need for us to waste these things lets them have more time to do patient care. I'm interested to see, if there's any studies out there looking into them performing their patient care better, because they're not having to focus on waste or other, I don't want to say mundane tasks, but tasks that, we can eliminate for them. And that way they can focus more time on their patients instead of focus more times on documentation or looking into waste. And yeah, like you said, we did with the fentanyl, we made a huge impact on the ER and then also the inpatient care units. So they don't want to go back to the change. I did see if you guys are getting ready to implement fentanyl, our wholesaler, it's on back order right now, but there was a 25 mic per half mil, I think, syringe. So they do make that, and we haven't pushed that one yet because most of our doses are 25, and that would basically eliminate all of our fentanyl waste. But since we just got done performing all these other implementations, we want to kind of give it a break, wait a year or two, make sure that manufacturer gets a pretty good stock before we make these changes. Because otherwise, if we make the change and then we run out of stock and then there's not a lot of buy-in and they just want to change back. So that was interesting. I was looking on our wholesaler. I was like, oh, hey, this is a new strength we can get. Let's do this all over again.
That is interesting.
Yeah, I think once you kind of get it figured out, and I think it's neat looking into informatics, looking at the data points, and then you have actual real data to show the C-suite or show the pharmacy directors on this is what's happening. This is real data. If we just change this one little thing, then we eliminate most of this stuff. And like you mentioned, the PACU, so the perioperative and intraoperative settings, those are pretty hard to change. We did those a lot more post-study. So we were kind of hesitant about it, but we provided them with 1 mil, 2 mil, 5 mil fentanyl in those areas. And then the CRNA anesthesiologist that's performing, sedation or pain management practices, they, by experience, can pick whatever size they think that case is going to need. So based on the patient specifically. And we've had a couple individuals, our chief CRNA down there, he kind of championed this and he's been educating those individuals. So creating that buy-in with that group, it was really nice having that person to, preach that down there, because sometimes when a pharmacist goes down there and says, hey, we want to change this, and then you have providers that are in the mix like, we don't want to do that.
Yeah.
Thanks for saying that.
That's the biggest challenge. The biggest challenge is the buy-in from all the providers,
in the cardiac cath lab.
Yeah. Yep. That's the biggest challenge for sure, because we also utilize the little boxes, the trays, to try to make it as simple as possible, and just based on their preferences and the things that they like and need, it's hard to change that. So yeah.
It is hard to change it, but if you do monitor it, then you can see who's shall we say, abusing that and pulling out the larger volumes, when they don't really need to.
Yeah.
And if that's
And
consistent, then you can.
That's kind of that's what we've been doing is every month. I don't have to do it as frequently now, but when we first made the change, every month I would look for outliers and say, hey, this person, pulled too much for this case, or they're not wasting it in a timely fashion, anything that made them an outlier. And then that individual would go and coach those new CRNAs, is mostly when we had travelers or people who were here for a short stint of time, and then we'd get new people in. That's when I noticed the fluctuations. So just watching the data every month and saying, hey, do you mind, touching base with this person and seeing what's going on? Because it may just be they don't know our hospital practices and that it's different from what they're used to at their hospital.
Yeah, and that's great. Having an advocate down in that area to help you, that is so, so important. Makes a huge difference.
Yeah.
Okay, well, this was great information. So I think you both kind of proved what we intuitively know, but you put some numbers to it, and then it's easier to sell the leadership on. And as we mentioned just very briefly, it's it's the pharmacy's budget. So if it's going to increase their budget, there's got to be a reason that something is being decreased, right? And so hopefully leadership looks at the big picture and it's like, okay, I won't ding the pharmacy for spending $1 more on those syringes, because look at all of the rest of the savings and the diversion mitigation benefit and so on and so forth, right? That's all important. So it's one big package. Yeah. All right. Well, thank you both for taking the time to share your research with us. I really appreciate it. And there's a lot of good information there.
Yeah. Thanks, Terry. Nice to meet you, Kayla.
Yeah, nice to meet you all. Thank you so much for having us.
Absolutely.
Yeah, thanks.